Welcome friends. In this video, let us discuss about stridor in a child. Stridor is a high-pitched noise originating from the larynx or trachea. Anybody can develop stridor, but why stridor has a greater risk in infants than in older children and adults? In infants, the airway is small, so even a minimal amount of mucosal swelling can result in a greater degree of obstruction and can result in stridor. Stridor develops when there is an increased resistance in the airway. So coming to the airway dynamics, Poiseuille's law states that the resistance is inversely proportional to the fourth power of the radius. So if there is an airway obstruction of 50%, the resistance is increased to about 16 times. And according to Bernoulli's principle, when there is an increased airflow velocity, it results in the negative pressure on the walls of the airway and it leads to inner collapse, further leading to increased resistance. And when the turbulence increases, again there is increased resistance. This airway collapse and increased resistance will lead to vibration of closely opposed tissues and it will result in the noise of stridor. We need to know the difference between a stertor and a stridor. Stridor is a high-pitched sound arising from the larynx or the trachea, whereas stertor is a low-pitched noise, snoring type of noise arising from the nasopharynx or the oropharynx. Coming to stridor, it depends upon the site of obstruction. If the site of obstruction is supraglottic or glottis region, then it is inspiratory. If it is in the subglottic or upper trachea region, then the stridor is biphasic. If it is in the lower trachea, then it is expiratory. Coming to the voice or the cry of the patient, if the obstruction is in the nasopharynx or oropharynx, then the cry is muffled. In the supraglottis or glottis, it is hoarse, whereas it is unchanged in the rest of the two. Coming to the cough, cough is typically absent when there is a nasopharyngeal or oropharyngeal obstruction. In supraglottis or glottis, the patient have a barking type of cough. In the subglottis or upper trachea, the patient will have a brassy type of cough. If it is in the lower trachea, then the patient will be wet coughing. Evaluation of child with stridor. History taking is really important in a child with stridor. We need to know about the perinatal and the obstetric history. If a child was born prematurely, it might have required ventilation and it would have been intubated. This would have led to stridor. And also a history of difficult delivery is also linked with vocal cord palsy. So a stridor present at birth, it can indicate a laryngeal web, subglottic or a tracheal stenosis or a bilateral vocal cord palsy. But if the stridor is developing after few weeks of birth, then it would have indicated laryngomalacia. We need to know the pattern of stridor. In laryngomalacia, typically the stridor is better when the child is at rest or asleep, but it is worse when the child is crying or feeding. But in contrast, if there is an upper airway or pharyngeal obstruction, this noise is worsened when the child is asleep. That is, stertor is worsened during asleep. And the airway obstruction is greatest in supine position in conditions such as micronathia and tongue-based occlusion or a pedunculated laryngeal mass. We also need to know about the associated features like apneas, cyanosis, dying spells, cough, hoarseness of voice, increased work of breathing. All these are described as apparent life-threatening events, that is ALTEs or brief resolved unexplained events. When there is a cough, it is rarely due to infantile asthma. We'll have to suspect tracheomalacia first in infants. And also, hoarseness suggests a laryngeal lesion. It might have been a papillomatosis, and also hoarseness can occur in vocal cord palsy. One might even need to know the feeding history. A change in feeding or inability to feed is typically noted by the carers and it is a key indicator of the upper airway status. If there is an aspiration, it suggests vocal cord palsy, tracheoesophageal fistula, neuromuscular pathology, or a laryngeal cleft. All this might even lead to failure to thrive of the newborn. General medical conditions like neurological disease or a cardiothoracic surgery or a congenital cardiac disease with a vascular compression can lead to vocal cord palsy. One should also note this. If there is an acute obstruction, then there are two possible causes. One is acute infection and in foreign body inhalation. The symptoms associated with varying causes of airway obstruction is prolonged expiratory phase, cough, aspiration, hoarseness of voice, acute airway obstruction, dysphagia and apnea. Let us see the various causes of upper airway obstruction. I have listed only the very important ones. Nasopharyngeal or oropharyngeal obstruction. Congenitally, it is due to choanal atresia, craniofacial abnormalities, micrognathia. Acquired in neonates, rhinitis. Acquired in children, it is due to allergic rhinitis. Laryngeal causes. Congenitally, it is due to laryngomalacia, vocal cord palsy, laryngeal stenosis, web or a cyst. In neonates, acquired, it is due to intubation trauma. Acquired causes in children is due to intubation trauma, croup, recurrent respiratory papillomatosis, foreign body, epiglottitis. Tracheal causes of obstruction. Congenitally, it is due to tracheal stenosis, atresia, trapped tracheal first ring, primary tracheomalacia and secondary tracheomalacia due to a vascular compression. Acquired causes in neonates is due to post-intubation or instrumentation or tracheal stenosis. Acquired causes in children is due to croup or foreign body. Examine a child with stridor. Initially, we will have to observe the child at rest. Any abnormal sound, wheeze or cough will indicate the localizing point. This cannot be done with the help of a stethoscope because of variable transmission of sound through the thorax. However, auscultation is important to identify abnormal heart sounds and wheeze. We should also note the associated features such as nasal flaring, head bobbing, abnormal posturing and cyanosis. Here, cyanosis is a very late event. It suggests severe obstruction. We should also observe the child attempting to feed if we suspect aspiration concerns. We should also note that if the obstruction of the airway increases and there is diminishing airflow, the volume of the stridor can paradoxically reduce. Thank you.